on the phone. That's great. Okay. Find your name card and have a seat. Make yourself comfortable. We have a really full agenda today, and as promised from last year, we spent a lot of time in 2017 laying the groundwork, talking about conceptual models and so on, and I think we're all a little bit weary of that and ready to get into some pretty substantive issues, which is what we're going to be teeing up starting today, which is why we have a full agenda. There's lots to consider, and we want to allow enough time for everyone to chime in from their own perspective, because these are the meaty issues that, this is just the beginning of the meaty issues we need to be considering as we talk about Medicaid payments, integrating care, aligning incentives and payment with the care outcomes that we're looking for in a world which is still fee-for-service driven. And so we're going to be touching on all of these elements. Mike Dudas is going to be showing us a model that has been developed over the last year with data out of New York, being guided by data out of New York and Medicaid populations. Lot to consider there on pediatrics. Scott Cronlin and Ellen Fisher are going to be talking about some ground-level experience focused on administrative issues, the problem that we all just love about eligibility on a monthly basis. It causes lots of downstream effects, ending up in poor data quality. So without further introduction, I think I'd like to get right into the agenda with Mark, capping the feedback we got in the survey in December about organization meetings, focus, how we're going to be spending our time.
Great, thanks, Rick. Welcome, everyone. Thanks for showing up. I hope that one of the things we did listen to in terms of the survey results was that people preferred a location closer to CTAC, and so as you see, we've done that, so I'm hoping that that'll help with people's travel and attendance. I want to take a quick moment to remind ourselves of what we did last year, because it's not insignificant. This really follows the agendas that we had set up for the meetings. We examined the VBP landscape and the expectations from the Healthcare Authority. We explored provider capabilities that are needed for VBP with the assistance of the team from MNAT, and those elements are listed on the slide: governance, organization, et cetera. We supported and advanced the provider survey, not an insignificant task, and got some good results, as you recall, from that initial survey. And then finally, in our last meeting, did some more exploration of the role of the ACHs in advancing VBP. And I want to take a moment to highlight this notion of role of the ACHs and use it really as a reminder, and picking up from what Rick just said. We really want to emphasize the action part of the MVP action team this year, and especially with respect to the relationships that folks around this table have with your respective ACHs. I'm sure all of you followed the homework assignment that was in my email in terms of having some dialogue with your ACHs. If not, we'll be sure to embarrass you appropriately. But I'm really hoping that that's an indication in the beginning of a fairly continual dialogue that you can have as you go back, not only to your respective organizations, but talk with folks from the ACHs as well. Because really, the ACHs will be looking to this group for guidance going forward with respect to how we carry out VBP, and we'll actually address that in the latter part of today's agenda. Some key takeaways from the survey that we asked you to fill out. This was the Survey Monkey we sent around. And just 3 points I wanted to highlight, and we'll try to be true to. One is people seem to like the large group, small group format we've engaged in, but please continue to give us feedback if that does or doesn't work. So we will try to make sure that there are opportunities both for presentation and also for discussion. An emphasis on using case studies and concrete examples. To pick up again from what Rick said, moving from more theoretical discussions last year into more concrete examples and specific applications of those theories to the needs of the ACHs especially, and the provider communities they serve. And And then finally, to be action-oriented in supporting and guiding ACHs. So that's about all I wanted to say, and I don't want to take up more time because we've got a full agenda. So I think at this point, I'm moving it on JD, so I'm going to clicker.
Thanks, Mark. So I just wanted to take a few minutes to provide an update on the Healthcare Authority's value-based roadmap and provide this group with a high-level overview of a rural multi-payer model exploration that the Healthcare Authority is engaged in at the moment. A colleague of mine, Gary Swan, is really leading that effort, but in an attempt to kind of share the load, I wanted to give the update to this group today. First, on the value-based roadmap, and this is a refresher and something this group has been familiar with throughout the survey and things of that nature, but we are basing our terms and definitions on the federal framework created by the Healthcare Payment Learning Action Network, and we are defining value as those plans and those contract arrangements that fit under categories 2C and above. Importantly, these subcategories and subcategories include payment models that tie payment to quality. So that's our working definition. Yes.
So I have a question on, and perhaps someone can help clarify. My understanding is that with the recent early adopters coming on board, apparently some of the behavioral health agencies in that arena were underneath a capitated system. And what I've heard, and I just need verification, is that they're now not able to sustain a capitated system because they're coming underneath multiple MCOs, and therefore they can't do it. Before it was one payer system, now it's multiple payer systems, and so they can't do a PMPM for those behavioral. Do you have anything to speak? Because that essentially our goal is to be at the top of the stair step here, would be my understanding. And if that's not, I'm concerned because I'm a capitated agency that they're going to be an on-time adopter, and I don't want to see things go backward. Do you know anything about that? Can you help me out?
So I'm not fully aware of the details of those contracts or payment arrangements. I don't know if anybody, Mark, James, want to add anything.
Anybody else?
I've heard the same rumor, twice. I think it is an issue we need to learn about and bring it to this table. Because I think what you're raising is the broader issue of how do we do it. There are a lot of people out there who really want capitation in primary care, but there are a lot of details underneath the topic, so I think this needs to come to this table.
Yeah, we take full capitated risk with our friends at Molina, and have done so since the mid-90s. And we have about 21,000 members that we're at full risk for. We actually we're a mid-adopter, actually decided to carve out behavioral health for this year. But
carve it out
from the cap payment. So historically, we've taken risk for the behavioral health, but this year we are not.
Right. And so, like my agency does full risk and full capitation, so that'd be a different animal bringing that.
But just to confirm, yes, this environment is really making it difficult to continue to take full risk. We're one of the largest rural health clinic system in the state, and the enhancement reconciliation, some of the stuff coming down the prior auth, I think, program that's going to be starting.
So I would ask what degree you are having active discussions with HCA staff as you're discovering this.
We have not had a lot. Normally, we've been communicating with Molina.
So based on Mark's comments, I think one of the things that needs to happen here, and we can certainly lead in this respect, is begin to build bridges with the ACHs around the state, because I think this is how we're all going to learn. We need the case study examples of why it is or isn't working, so that at a policy level, changes can be fine-tuned.
It's good to hear from the NCO folks as well about what they're doing in that arena. I know there's a lot going on. I don't know if anyone's ready to speak to that today, but maybe there's something.
I would just say, I know in North Central Washington, and I'm not involved directly in behavioral health provider contracting, but I know that we've entered into arrangements that are a modified form of prepayment, so it probably doesn't look exactly like the cap that it was in the previous years, because it was one payer, but it's not that it's reverted to a full fee-for-service model.
But did it go to case rates, bundle rates?
Well, that's where I can't give you
Oh, yeah.
the exact details, other than that I know it's a prepayment, but, I'm sure, like, Rick is saying, we can kind of delve into that and try and figure out.
Because that's where our ultimate goal, so maybe it'd be helpful if we knew, how do we back up into it, or how do we support getting there?
So, action, step is if those who have experience, concern, evidence, whatever, so far, from your respective ACH, if you could let Mark and me know, maybe we could pull together a subgroup prior to the next meeting or next couple of meetings to have a rational, coherent presentation of different perspectives.
Congratulations, you made it through one slide.
All right, and before I move on, I do want to make one comment on something you said, Joe, about this being kind of a step ladder. While it's easy to look at it that way, we don't want to treat 4B as the target for everyone and for every provider group and every provider type. There might be folks that won't work for them, and maybe will in the future, but we don't want to set that as the expectation. That being said, we don't want to tie hands of providers who are, capable of operating in that environment and then forcing them to, as you said, move backwards. So
I think that is a key part of my concern. It wasn't necessarily drag everyone there, but necessarily not dragging them back or backwards.
So, yeah.
Thank you.
All right, slide 2. So our value-based roadmap is built on 7 foundational principles that we are trying to integrate into all of our transformative efforts. That's rewarding patient-centered, high-quality care, rewarding health plan and health system performance, and this is where we tie the quality to payments. We want to align payment reforms with what's happening at the federal level. A lot of that has to do with tracking MACRA programs and how they're tying payments to quality and how they're tracking transformation in the payment world. We want to see improved outcomes, and measurement has a lot to do with that. Standardization of measures and contract arrangements and how we're assessing performance. We also are leaning on groups like the BRE Collaborative, who put out evidence-based standards and recommendations for payment models, and we're integrating those into our contracts. We hope to and aim to increase the sustainability of state programs and our partners. We don't want to see a restriction of access to our members and to Apple Health clients. And then, of course, we are always keeping the triple aim and the quadruple aim in sight as our North Star, so to speak. So we've set targets for each year to increase our value-based purchasing. Beginning with 2016, we set the target at 20%. We measure this on an annual basis in the fall of the following year, and this past fall in 2017, we measured calendar year 2016, and we're actually 10 percentage points ahead of that goal. So that's a good starting point. The goal gets, accelerates at a quicker pace every year, so we still have a lot of challenges to get to that 90% by 2021. The roadmap also serves as a means for us to communicate to the public about our goals and the initiatives that we have in place across our programs. And we have a one HCA roadmap, as we call it, within the agency, which kind of includes a high-level view of what we're doing across our public employees and school employees programs, and then also our Apple Health programs. And then there are 2 appendices that go along with the roadmap. One that does a little bit deeper dive into the employees and retirees benefits programs, and one Apple Health appendix that goes into more detail on the Apple Health world. And the Apple Health appendix focuses, as I said, on Apple Health programs, talks about strategies that we're using to support providers that participate in Apple Health move to value-based arrangements, describes our targets and how we're measuring and how we're planning to achieve our targets, talks about our new contracts with the MCOs, with the 1% withhold, fully integrated managed care, then discusses the surveys that we put out. The Apple Health Appendix is also a requirement under the STCs with CMS for the Medicaid Transformation Demonstration and is an annual deliverable to CMS. The Apple Health Appendix was published in the fall of 2017, and I believe we're still awaiting feedback from CMS. So it's going to be kind of a living document. The Employees and Retirees Benefits Appendix goes into a deeper dive of what we're doing on the public employees and the school employees side. HCA this year was charged with building out the School Employee Benefits Board program, and over time that will take a lot more significant shape. Right now it's pretty conceptual and high level, but we're aiming to align the Public Employee Benefits Program with the School Employee Benefits Program and lean on a lot of our learnings and contract arrangements and benefit programs we've developed in that program. And we're really striving for alignment across programs. One important thing I want to call out is we built a quality improvement model in the Accountable Care Program, which is our ACO arrangement for public employees, and we were able to leverage that same model in the MCO contracts. And so it's an illustration of how we're trying to provide consistency to our provider partners, but also in how we're measuring and paying for performance. And the employee, and then this is the status of the roadmaps. As I said, the Apple Health Appendix was published in the fall of 2017, and this January we published the high-level agency-wide roadmap and the Employee and Retiree Benefits Appendix. Those can be found on our Paying for Value website on the Healthier Washington page. And unless there are other questions on the roadmap, I want to move on to just a high-level description of what we're intending with this rural multi-payer model exploration. And as I mentioned, my colleague Gary Swan is really the champion for this and at the Healthcare Authority, so I will do my best to describe what our intentions are and where that stands. And I'd be happy to take questions and perhaps loop Gary in at a later date. But in conversations with stakeholders around this work, he's pulled together some findings and some specific challenges that rural providers face, and recruitment and retention come to the top. They treat generally a sicker and older population, operate on very small margins, and have found that relationships with larger systems have not really been beneficial to sustainable operations. And I went ahead and looked at the provider survey that we did and pulled out findings from critical access hospitals, federally qualified health centers, and rural health centers, and also tribal health clinics. And the barriers that they face and they noted are pretty similar to this, although we didn't ask questions or pose options that were directly lined up with this, but they talk about misaligned incentives, low patient volume, lack of comprehensive patient data, and financial information and financial stability. So we're hearing a lot of the same things in our various means of communicating with providers.
I'm curious, maybe it's embedded in your transportation is something I always hear about my colleagues in the rural areas. It takes so long to go from point A to point B to deliver, an hour to get there to do 30-minute service, and they can't bill for the transportation. So, I mean, they're getting slaughtered on that part. They don't have an infrastructure for transportation to get people from A to B to come in for services to a hub and spoke model. It doesn't work either. I don't know if that came up in this discussion, or is that something outside the realm of this?
So I can't answer that. I'm really just now getting involved in this project, so Gary would be more like.
You want to make a note to Gary, or?
You got it noted.
Yeah.
So, given these challenges and the importance that rural health providers play in sustaining state programs and also the health of the statewide population, we've realized that we need, a significant effort to transform the way we pay for care and the way care is delivered in these settings in order to ensure sustainability and improve quality and address some of these challenges. So we've begun, Gary has led an extensive stakeholdering process over the last couple months, and has begun exploring ways that we can transform rural health delivery system. He's looked at what other states have done and tried to take some learnings from other states. Pennsylvania and Maryland and New York, I think, have done quite a bit of good work around this. And Washington is a different animal, and we're going to have to take a unique approach, but there are aspects that we can build on and steal from those states. And the goal of this model in building it out is really to build something that's collaborative and that does actually transform the system and gets to a more budgeted approach that would provide some predictability for providers, would ensure sustainability, and would also give us a way of measuring and tracking and improving outcomes. The model, as it's very conceptual at this point, and we're not trying to build something and then ask for people to buy into it and say, yes, we'll do it. We're trying to come up with a framework and some goals and have a more community-based approach of putting the details of the model together. But the 4 goals that we've identified are making this reform and transformation value-based in nature, that sustainability is the primary objective and always in focus, that it is getting a delivery system-wide transformation, and that patient engagement, patient concerns, and patient challenges are addressed in the model. The timeline of where this is and where it's been and where it's going in the immediate future, this month is really focused on individual one-on-one meetings with payers to get input. We want this to be a multi-payer engagement, so we want buy-in from both Medicare, Apple Health plans, and commercial payers. We're looking to identify some champions that would work with us and really take a leadership role in moving this forward. And also trying to find and identify concerns or challenges that we have not yet identified, and ways to build a model that will work and will present an opportunity for folks to participate. In February, we're going to start the month off with a convening on the 1st. It'll be a meeting with MCOs, commercial payers, and providers that have been engaged thus far in conversations, and folks that we hope to engage in the future. We'll provide a background of where we've been and a framework for the discussion moving forward. Gary's worked with some folks within HCA and throughout these conversations to build kind of a straw man model that we can potentially start with. It really focuses on the interplay between hospitals and primary care, a way to bridge the gap between the two and ensure that hospitals are able to maintain operation and that payment is connecting primary care services to those necessary and important hospital services. They hope to build out a timeline for putting a more concrete model in place and likely getting some legislative support. A huge challenge to this and opportunity is getting support from CMS. Rural providers, on average, see about 50% of their business in Medicare. So getting CMS buy-in on this model is going to be hugely important. Also, looking forward, if we do get a model in place and approved by CMS as a multi-payer model, it could qualify as an advanced alternative payment model under macro rules, which would give participating providers an opportunity to participate in the qualified payment program that would give them a 5% incentive payment under those rules. So there are some federal incentives at play that we think will sweeten the deal to some extent. And then at the end of the month, Gary will be running a webinar on the topic to give an update and status where it has been and what the next steps are. And that will be on the 28th. And I believe our new director, Sue Birch, will be participating in that one. So any questions on where we are on that?
Challenges listed here is also present for urban federally qualified health centers, community health centers, plus higher cost of operation because they're in densely underserved areas. Also, the roadmap that you have, especially relationship authority, awarding contracts to MCOs, there needs to be better clarification of how the dollars for quality that are being set aside can be spent on quality to the providers, because for 2016, we have seen, women providers, we have seen different interpretation of MCOs in terms of how they want to release these funds to providers. Some MCOs are tying that to meeting a list of quality measures. Either you meet all or you lose the 1%. Some of them, they have that in their contract. Some, they have a different interpretation that if you meet like 70%, then you are awarded the 1%. We actually had a lawyer look at it, and the result of lawyer's interpretation was that the contract does not require meeting all or lose results. So healthcare authority can do a better job in terms of clarifying how these dollars will be spent or awarded.
One thing I'll note, Herman, to your earlier point, I know one of Gary's kind of thought partners in the development model has been WACMIC as an organization, and also some specific FQHC representatives. So I know there is sensitivity to this applying to federally qualified health centers generally as well as rural providers.
And I think that the goal is to create structures within the contract, but not to dictate those contracts. So some of that sort of may fall into the individual terms of the particular contracts, which HCA wouldn't be dictating what the specific terms were, but hopefully could be helpful in, communication to make sure that whatever the terms are, they're clear and the MCOs and the providers are.
Yeah, it should be the clearer, more transparent. It's going to be easier moving forward. Otherwise, it's going to create a lot of friction.
How's the current pilot going with the FQHCs and RHCs?
Could you repeat that, please?
The current pilot program, I think that started.
Alternative methodology for it.
Yeah.
I don't have detailed answers to that. Again, that's Gary's work. But anybody else has any insight? But
And we could probably bring back, either send out or bring back an update for this group as to the status on 18.4.
I know they've successfully been able to share data, and from that perspective, things are moving well. I don't know what the impact has been on the provider side from the infrastructure side of actually getting data out the door and getting that process in place. It's been going well.
Before we leave the topic, and Herman, to add to what you said about the community health centers, I think we could add to the list of people who are having trouble with rural issues, also applies to smaller independent practices as well. So I think when you total them all up, this is kind of a big issue.
All right. Okay. That's it. Thank you.
Any more questions for JD before we leave?
Yeah, one more. More a statement than a question. One of the things I would expected to see in this section was calling out the role of telemedicine as part of the solution.
Yes.
I mean, that very clearly gets to the transportation issue, it gets to the cost issue, it gets to the urban-rural connection issue, as well as the inter-rural connection and how you link providers to a central location. I mean, it's a solution out there that's available, it's fairly right. The primary barrier that I've heard of is we have outdated, obsolete payment rules and also coverage rules for services that are provided through a telemedicine portal. So I think that's something that's clearly within the state's ability to be able to influence and change. And I think if we want to make significant improvement in both cost as well as quality of the care that's delivered in the rural areas, as well as I think in the urban areas, I think you see the same thing sort of clinic that Hermes is talking about. We've got to take some of the barriers out of the implementation and utilization of telemedicine.
I mean, I think there's although psych and telehealth is a good option. What we're failing to acknowledge is that the state lacks a fiber infrastructure to support that, especially EHRs as well. So a lot of our rural counterparts are really on nickel and dime cable systems and that, so it actually compromises the ability to expand that, at least from my experience. Unless we want to give them satellite access, I don't know. I don't think anyone wants to pay for that. But I agree with you, but it's just at the same time we don't have the road to build it on, the connectivity.
Yeah, that's a very good point, because a lot of primary care providers have difficulty finding and referring patients to specialists. And telemedicine is a good way to do that, but the rules are outdated. Even state rules specify a valid visit to be face-to-face with the patient. So a lot of rules need to be updated in terms of what qualifies as a valid visit with the patient. That should include telemedicine.
I think there's an excellent point here, because when we're talking about how do we exchange information across an electronic health record or telemedicine, the fact that what it really calls for is more of a public utility model, something that's standardized and can be bought into by anybody out there. That makes it cheaper, that makes it wider available. Instead, we seem to be going on to a proprietary model where each health system is creating its own fairly unique one. That's not going to work going forward. It's going to be a continued barrier. So I think that's one of the things the state can weigh in on and help with. I mean, the state is involved in a number of IT development projects right now related both to EHR development as well as some other future development issues. And I think we need to take a look at those, or we need to understand how do we develop those more toward a utility model. Or again, you're just going to create barriers, that you're going to create silos that are going to impede really the implementation or transformation of care.
Thanks for that. And I will bring back both the transportation concern and the telemedicine thought to the group.
I don't know if transportation was being attributed to you, but also add to that list the, call it last mile, interconnectivity. There's just no internet service in vast portions of our rural areas, and that's going to impede any type of technological assistance, whether it's telemedicine or just exchanging even basic information. I was in Clickitat County the other day, and huge dead zones everywhere I was driving around. And the other piece, which sometimes gets lumped in with the interoperability of health information, but in my mind is very different, is the data. If we're going to expect providers to move to value-based payment, we need to provide them with the data that allows them to do the internal tracking that they're going to need to do to become proficient and to accept some of the risks for their patients. And right now, we do not have success in sharing that level of data with our providers across the state.
Thanks for that, Dawn. So I think what's happening here is we're beginning to make a little laundry list of issues that need deeper exploration, and that this committee could take positions on as recommendations for further action. Certainly, HIE has been a topic for 12 years at least in this state, and I don't think we've made much progress. We're not on first base yet. So, lots of work to do. Duly noted.
And I would encourage folks around this table and on the phone to participate in meetings around this model and the webinar moving forward. I think your voices would be very much appreciated and heard, and we'll commit to continue to keep this group updated as we move forward regardless.
Could I just second Don's comments that our lack of access to data is, to me, one of the single largest impediments, if not the largest impediment to us engaging in any kind of value-based contracts with risk.
All right, so given given the time, I think we're ready for the next topic. Just to frame it for Mike, over a year ago, Mike and Francie Chalmers have been working through the Washington chapter of the Academy of Pediatrics, and in that process looked at about 4 million lives analyzed from New York State Medicaid, adult populations about 2 million kids, both financial per person costs and as well as utilization. The picture that jumps out from the analysis of that data that was conducted by Baylor Health is a mind blower. So Mike and Francie pulled me into their annual meeting in November of the Academy, and very interesting discussion day long about the differences just in primary care and what we're trying to achieve through not only integration of care with behavioral health, but also trying to align incentives around what gets done by providers of different types for different populations, the follow through, and how you get paid for that. And the data show that, in fact, there are such differences, fundamental differences between adult and child medicine, that are one size fits all ain't gonna work. So I encourage them to get that discussion going at the table. So Mike, take it away, because you've got a very coherent deck.
Well, thank you guys for having me today and focusing on this. This really started, so I co-chair the Healthcare Transformation Committee for the Washington chapter, and this really started last year when we were realizing that pediatricians across the state don't really understand value-based payments. So this actually began as an effort to really educate providers on value-based payments. And as we dove deeper into it, we realized we need to also understand what is value in pediatric care and really understand what are payment models that have been used in other parts of the country. At the same time, PMMI was trying to gather some information about thinking what would a pediatric payment model look like. So all of that came together this past summer when we found Baylor Health, who had done some really good work that Rick alluded to in New York State a year ago, and analyzed some really interesting data. And there were a lot of parallels for the work that we're trying to do in Washington State. So thank you. We had the opportunity to present this to the Healthcare Authority back in October and to a group of MCOs. So you guys are obviously all familiar with this, what we're here talking about. So the state's vision of being at 90% of provider payments under value-based payment models by 2021. So, you know, most of the discussions across the state and across the country have really focused on adult care and conditions as we've talked about value-based payment models. And it makes sense because adults make up the biggest part of the spend. Interestingly to me, as I really looked at the numbers, so in 2016 it surpassed $10,000 per person per year. And if you look at pediatric spend, the average is about $2,600 per person per year. So a whole lot less. The even more interesting thing to me was looking at the amount that we spend on an adult in their last year of life, which is about $34,000 per year. So just thinking about the discrepancy in those numbers, some of it's very appropriate because adults have a lot of chronic health conditions that need to be managed. But I also think about, wow, if you took that $34,000 and put it in the first 5 years of a child's life, how could we impact the health outcomes over the course of a lifetime? So, you know, I think the numbers are really important to think about where we're spending our money. Sorry, that was a tangent. Let's see. So again, we need to figure out where is the value in kids, and we know that there is a lot of value there that isn't necessarily being pulled out of our pediatric care providers, and we're also not paying for it. So that was really what we sort of dove into. The other piece is that 45% of the people covered by Apple Health are children, and if we're going to get to 90% of payments by 2021 in value-based models, we really need to think about what's the appropriate payment model for pediatric care. We do an outcome. Let's see here. So value-based, so again, this is really about, and I apologize, some of these slides are from Baylor, value-based payment models are really focused on value. And really the value of kids is not so much the chronic condition, but the value that we put into their health care that's going to impact basically their health trajectory throughout their life. We, at the ending to this group's credit, you guys have talked a lot about the social determinants of health, and they really thought about how do we integrate these important aspects into value-based payment models as we begin to think about it, and also how do we support that through the accountable communities of health. So this is obviously a key when we think about pediatrics, and in particular, if we think about adverse childhood experiences and the impact that that these experiences can have on health trajectory throughout a person's life. So these things really need to be accounted for as we think about how we are delivering care to kids, but also how we're paying for that care. Excuse me. The challenges. Thinking about the challenges with designing a value-based payment model for children's health care, really, so one, it hasn't been done before. This model that we're talking about was something that was put together and designed for New York that hasn't been implemented yet. So there really isn't a model, especially as you think about primary care, there isn't a model out there that's been tried and tested, but a lot of good thought has been put into this. So I think it really is probably about the best potential model that's available to us. One of the other challenges is again, children generate very little medical expense. We were not really thinking about the model from the perspective of cost savings. There are very few kids with high medical needs, and that is about 1% of kids that have a very high medical need. The challenge with thinking about payment models for that group is that it's a very heterogeneous group. So it's not really about a single condition that you can focus on, but a large amount of tertiary care and specialty care that needs to be provided for those kids. Really, a lot of it at tertiary referral centers. So you're not going to have a large group of kids that you're going to be able to do a total cost of care model with outside of the large tertiary care facility. Excuse me. I think one thing that's not up here is I think about it, you look at the tiering of the least expensive kids to the most expensive kids, right? So the tertiary, the kids with medical complexity are the most expensive, and the least expensive are the healthy, maybe 85% of our population. The kids in the middle, the biggest cost driver is behavioral health. So as we think about models for value-based payments, integrated behavioral health and paying for that is exceptionally important.
What did the data suggest adults compared to children when it came to behavioral health?
I don't know the adults compared to children for behavioral health. I don't know. I think, as I was talking, I forget, to one of the, I think it might have been someone from Molina, might have been Angela, we were talking about, she was looking at their most expensive adult, most expensive people that you guys cover, right? And there were 250 of them. And she said only 2 of those were pediatric patients, right? But my question for her was, did any of those patients have conditions that started in childhood? And the response was about 50% of them had mental health, behavioral health conditions that are leading to that. So there's a really strong connection between how do we care for the behavioral health needs of kids and their future, healthcare expenses.
So I'm sorry, may I interrupt you?
Yeah,
I'm struggling with, when you talk about few kids have high medical needs and low amount of money paid to kids, and probably, if anything, this kind of applies in the face of ACEs. Obviously, if we take ACEs as a evidence-based practice, and then it's really out there, we're doing somewhere along the line, there's a potential, is there a bias towards spending on children or seeking services for children that could benefit, or is the lack of access to services that you, I'm really struggling with your assertions here, because they don't resonate with my experience. But then the flip side of that is that even if you were to go ahead with value-based purchasing for kids, you know, the kicker I find, and that, for example, in our ACH, we found, we completely threw out preventative projects, care projects, because the return on investment is generations out. And there's no way in hell I'm going to enter into a value-based payment program or MCOs and say, oh yeah, 30 years or 5 generations from now, we'll check up to see if you really made a difference, Joe. You know, I'll be dead, buried, and gone, hopefully by then. But my point there is that it's really difficult when you talk about investing in kids. It's going to take a different type of approach than I think the current optics that we're using, and that what's being generated here. Does anyone share that concern, or am I just...
I made the same comment I just wrote down here to be said later on, which is when we're talking about model, especially with kids, we have a problem because those who might pay for what will have the biggest impact later on don't see that benefit immediately, so it's not a natural connection, and it doesn't fit their business model. And at no point do we discuss where do those streams of funding come so that we can start to address not only the immediate, but what we know is going to just continue to be that cause year after year, generation after generation. And so as part of a value-based payment model, the higher level piece is how do you align who's going to receive that ultimate benefit with who's paying for it on the front end. And if we're just looking at payers, insurance companies, we're never going to get there because their business model is never going to pan that out. They don't know those members they're spending money on today are going to be their members in a month, let alone 3 generations from now.
Excellent point.
It's part of the problem.
It's part of the problem. And let's stop talking about prevention if we're not going to tackle it, but I think all of us want to do that.
That's our conclusion.
Yeah, well, okay. So your other points, Joe, I think at some point, this is not the only day we're going to talk about this stuff.
Okay.
It would be helpful to show the bailiff data from New York. You got 4 million lives, 2 on each side of the fence, and it is so remarkably different. Yes, different sources of data are going to focus or display different dimensions of and magnitude of problems, but just from a financial standpoint and utilization standpoint, the data just say, well, come on, now figure out how you're going to align incentives at the provider level in order to achieve what we already said are achievable and really things we should be doing for the entire population, not just Medicaid. I think that's really the point that Mike's trying to make here.
Well, I think part of it is the state pays for it all, even if the specific payer doesn't pay for it, right? I mean, that's like, you're paying for everything, and and the state's going to continue to pay for it forever, right? So,
but when the state pays for it, we still have the conundrum of, the elected officials in the legislature who appropriate the dollars find it really hard to go out and run every 2 years on, hey, I voted for appropriations that literally 15 years from now are going to knock your socks off, so re-elect me today. It doesn't work that way. Part of the conversation, maybe we just haven't gotten to it yet, Rick, but is if we shift what we're doing now and we save money, where are those savings going? If they're just going back in to do the cycle that we're already doing, we're not breaking the paradigm. Can we identify the savings and mandate that at least a portion of the savings go towards those long-term investments that it is so hard to get consensus around voluntarily making?
So some of the ACHs are already talking about things like an old guy like me used to call it the community chest in the town that I grew up in, on Long Island. And, well, everybody has some sort of a community chest, right? But now it's maybe through the ACHs, that's a proposal, so that could be done that way. But it requires a lot of, discipline. It requires the absence of politics. And, a dedicated, evidence-based drive toward, the fact that we know that millennials are gonna live less long than the boomers. Why is that? Well, for all of the reasons that we're talking about. So are we gonna change that or not? We're slipping, we're not advancing. Big, another comment?
Yeah, I would just say, I think that you're calling out those exact challenges, and as you go on, you're gonna sort of talk about ways to address those. And I think that, there's some of these things that are, if we ever let you.
We're gonna figure this out.
Some of these that are huge, big problems, and I think, sort of, Dawn, your question of if you make an intervention now that's 20 years down the line, where's all that coming in? And that's a big, complicated one. In the meantime, there are also a certain number of levers that we have in all of this, right? I mean, preventative measures are built into the MCO contract. If you don't meet them, you're losing money. And even though that's not about total cost of care, we have created a structure in which there is a certain amount of accountability for preventative measures that don't have a cost return on them. And we can continue to do that. We continue to move those levers. So there are, I guess I would encourage a little bit of flexibility in thinking about not everything is cost of care. And remember, only one of these types of categories is about total cost of care and value-based purchasing. There are a lot of ways to do value-based care that are not about, fundamentally, completely about, or heavily about total cost of care. So I guess I just would encourage us to not dive to the idea that we have to solve all of those big long-term problems in order to get to some really positive steps along the way. And more.
And what?
We'll let you keep
Oh, well, then the rest is really specifically around the recommended model. So the recommendations are for two value-based payment models for peds. One, a pediatric primary care advanced payment model, and the second, a more total cost of care population health model for children's medical necessity. The primary care payment model, we actually did some wordsmithing and took out the word capitated because people were so upset by the word capitation, and I think that you guys can probably all relate to that. We changed it to bundled care for pediatric services, but and the goal, we believe that there should be a bundled payment for most pediatric primary care, with the goal not to put financial risk on pediatric practices, because truthfully, just taking Medicaid is about the most risky contract you can take right now, right? So the goal of bundling it is so that practices can have the ability to do non-traditional services that are not currently paid for in fee-for-service, more screening, differences in screening, better referral, better care coordination. So they have that service delivery flexibility, and that they can also engage in models for more appropriateness of care in settings such as telehealth or just phone calls with families, which can be done a whole lot cheaper than having them in front of you. And also a goal of providing incentives to continually improve. So there's four pieces of the primary care model: the bundled primary care payment, care coordination fees, and then we've got targeted fee for service, because there's pieces of pediatric care that you don't want to limit, right? So one example is immunizations. You don't want to reduce the number of eliminations. You want to encourage as much utilization of immunizations as possible. So, and as well as things that can potentially be done in a primary care office that are often done in the emergency room, such as splinting and casting and suturing, that are now being sort of, because of the speed with which you have to see a patient, which you can no longer do in a fee-for-service environment. So we felt that there were some specific areas that really needed to be targeted fee-for-service. And then finally, a performance bonus opportunity based on quality measures and performance measures. I think I just actually went through all of that. We also thought that specialty and tertiary then the second model is advanced payment model for children with medical complexity, and really more of a total cost of care model, where a provider organization receives a budget if they have a sufficiently large population. So this is probably the most likely something that would be viable in our few tertiary care centers for pediatrics in the state. Thinking that it would evolve from shared savings to shared risk, and would not likely become completely full risk due to the high cost outliers. In addition, care coordination be in this model, just because of the importance of coordinating the care between both primary care and tertiary care for these kids. So challenges, which you guys were already starting to call out. So I think costs in this type of model are necessarily going to go up. One, because fee-for-service care for pediatrics has been underfunded for a long time. 2/3 of Medicare rate is half of about what it costs to deliver the care. And, looking at pediatric practices across the state, whether they're a small independent primary care practice or whether they're part of a larger health system, there's been very, very little investment put in care redesign support for pediatric practices. One, in the private practices because they can't afford it if they're taking Medicaid, and two, in the health systems because all of that energy is being put into adult care. So there's going to need to be some investment, which is why I pulled out category 2A and B, because there may need to be some thought put into how do we do that to support pediatric practices to do value-based care. And then also because care for improved lifetime health outcomes is not currently reimbursed, such as social determinants of health screening and care coordination. I think that was about all I had.
In discussions in the academy and elsewhere, does the topic of behavioral health, drop the word integration, but just behavioral health in general in pediatrics, get a lot of attention?
It's what probably we spent most of our time on in the past year or two. I think, it's for us, the perfect place to really focus our initial integration efforts, because there's beginning to be a payment model for it. It's a huge part of what we do, and it's going to have the biggest impact on sort of future outcomes, adult health as well as pediatric health. So we spent a lot of the last year focusing on how do we, some of it is how do we get paid to do some screening so that we can at least, feel like we're not just adding more, but also that we can do it more effectively. But also creating models for whether that's collaborative care, and we're working with Game Center right now on developing a collaborative care model that works for pediatrics for the different mental health conditions. And we're working even just with single provider practices to develop, arrangements, just coordination arrangements with local mental health providers to say, how are we going to share information, how are we going to coordinate care better so that we can provide better care to kids. So there's been a lot of work on that.
I had a question, maybe I don't know if you can or can't answer this one, but are you aware of the pediatricians taking Medicaid patients currently? Do you have any sense of how many of them are kind of an independent, primary care settings versus members of larger delivery systems?
I think the vast majority are independent practices, and as you've seen, like the Everett Clinic and the Vancouver Clinic and others have really, either closed down or stopped taking Medicaid patients.
And I guess corollary question, would you consider the provider base in terms of pediatricians seeing Medicaid kids, is there stability or is there volatility in terms of levels of participation in Medicaid? Has it been a fairly stable provider population, if you will?
I think
I don't mean mentally stable, by the way.
No, they're desperate. But I think with larger systems closing down to Medicaid, they've seen higher volumes of it, and truthfully, they can't. It's
about a 10 to 20% cost differential.
10, 20% what?
Cost differential. We have Okanagan County is just really difficult as far as access, and that is by far our most expensive.
Which drive that is the inappropriate utilization.
It's lack of access to primary care, and then I think they end up with ED and.
This might be a foolish question, but how do these models impact the providers' engagement with parents and outreach? I mean, when I think care coordination, I mean, parents of these children must need to be educated as opportunities and access needs of their children. How does that fit in?
I mean, I think by doing especially for primary care, a bundled payment gives you the option of providing the care that your patient wants a lot better. I would probably have my schedule a day as phone calls, because that's what parents prefer. They don't want to leave work. They don't want to get the kids. They don't want to bring them into the office. But for me to get paid for that kid and for them to get their questions addressed, they kind of have to do that, or I have to stay at night and call them later and sort of take the hit one way or the other. So I think it would help a lot to be able to provide care, I think, in a more appropriate, in a much more patient-centered way that would be what they would need. Is that what you're asking?
Yeah.
We've done some school-based experiments, both with behavioral and physical. So it's still learning, but it's been just logistically very, very difficult getting the parent authorization. So I think there's a big opportunity there if it's designed correctly to really connect with these children.
Other questions of Mike? Yeah, or comments, or concerns or questions?
You're going to be back, other than all the systemic issues that are going to make it impossible to do.
That's next.
I have a question for Mike, actually. Mike, you mentioned that the value is into adulthood. Are there any approximate markers that you and your colleagues look at in terms of identifying sort of value along the way, or predicting?
Like the long-term impact of doing this. So we're working with a health services researcher at UW right now. We're part of the TCPI grant with the Department of Health, and we've been able to engage one of the researchers at the UW who's actually putting those numbers together for us right now as we even just get more kids in for well child care and immunizations and other of the sort of basic measures. How is that going to impact later health, and put a number to it? So he's working with them to do that.
I was wondering about engaging children's CIN and maybe multi-care CIN. There's large congregation of many of the independents through these clinically integrated networks where some of the investments may have already been started or could be leveraged as we think about incremental. Just curiosity there as to how we might turn to them, because they already have to solve it for their commercial populations from a population health perspective.
So Cheryl Morelli, who is the medical director for the SCCN, is a partner on this work with us.
That's already happening.
Yeah, and a lot of the work that they are doing is focused primarily on the 1% children with medical complexity costs, as opposed to the rest of the primary care payment model. But they are very much engaged in the conversation.
I think the ultimate question, Mike, and this is though that, there seems like from a societal perspective, there's just inherent value in getting kids immunized, or whether, I don't want my grandkids getting polio or whatever. And somehow this whole notion of having, I scratched my head over this notion that we have to sort of prove value, that investing in the children of today is going to bring value to tomorrow, but we have to go out and try to measure that. When there's lots of data that says, you give kids polio vaccine, the rate of polio really drops substantially. You get kids into preschool, parents are they're not necessarily available to read stories the way that maybe they were when I grew up, you know, and things like that we, you know, somehow it seems like some of this stuff is kind of ridiculous, that there isn't just a general understanding and appreciation that these are valuable activities when you think about trying to just perpetuate our country, you know, into the future. I just find this really ironic that we're trying to, you know, measure what's valuable when we really kind of inherently know that already. Anyway, editorial comment,
No, but I think it's a valid point.
I think some of this gets back to Emily's earlier point about the kinds of measures that you use then, and are we able to tie a certain incentive to the things that we do know make a difference, and stop and not worry about, you know, answering the question of whether they do, because obviously they do make a difference.
It's a great summary point, I think, for the discussion, which is why we're going to revisit this, perhaps in a broader sense of adult versus child, alignment of incentives around payment because of those differences, let alone differences within populations, because everybody wins when it's well aligned.
Yeah, the only thing I was gonna share is, and clearly it's because it's experience driven, but the premiums associated with children's are so low. So for the Apple Health family population, drastically lower programs per month funding coming in. So it makes it really challenging then when you're trying to roll out value-based to a whole lot of different provider partners to make that work. And I understand what you're saying, Dr. Fancy, that, you know, there's a withhold that funds specific measures. So there's a piece of that, you know, there's a financial driver to, but at the core of it, it's that extremely low premium associated with the kids that makes it, I think, super challenging.
And the premium's still based on a fee-for-service model.
Right, which is, gee. So that's kind of okay, one more comment, move on.
A nice thing about metrics, even if they're not sort of, especially if they're not cost metrics, I mean, if you can show that a model is improving things that the legislature knows to be important, then you can make that case that if we do this, we have this value, just financial value. And I think it's possible to get people behind that. It's easier if you can show the impact in a way that tells the story. Something from all.
Well, Emily, that's a great segue into the next topic, which is actually has been broached as, so what are the administrative barriers to making change and getting improvement? And so we asked Scott Cronlund and Ellen Fisher to talk about a better than 5-year experience on around 12,000 Medicaid lives between United and a delegated relationship with Northwest Physicians Network in a number of different counties. Where the administrative barriers, which we are convinced nearly everyone in the room has experienced directly or indirectly and knows about. A concrete, call it a case example, and where does that lead your heads for discussion for additional kinds of questions of low-hanging fruit that this group could recommend that we do something about in order to reduce inefficiency in the Medicaid program in all aspects, so that the funds that are currently allocated to Medicaid can be maintained and go further. So, Scott and Ellen.
So, just a point of clarification, this is the only slide we have. We rebelled.
We did. We rebelled. But we appreciate it. So you can look at it all you want, but it's not going to change, right?
So there's some things that this work group has been talking about since we've been formed. We talked about attributes of the clinic in a value-based setting. You know, we did a lot of work in, if I remember correctly, 2 sessions about what is an attribute, what are the key attributes of a clinic in a value-based setting, what is necessary to be able to support that. We talked about barriers a bit. Some of the barriers that we talked about were real-time useful data, not claims data necessarily, but real-time actionable data in the physician's office when the patient is in the room. We talked about common measure sets, and so that we all have similar targets, and so a provider doesn't have to twist and turn amongst 5 different payers for 5 different targets. And so some of that has been tackled through withhold incentives. We talked about wraparound services, and accountable community health are talking about wraparound services. Do we support the PCP with integration from the
MCO with community-based or county-based organizations like that which supports food security or housing, insofar as housing exists. EMS services is wrapping around the PCP so the PCP can be successful. And we talked about, we talked a little bit about what the accountable communities of health are doing, and each accountable community of health is taking a look at what those community-based organizations and wraparound services really should look like in order for that physician's office to be successful in the value-based world. And what we touched on, but we really haven't driven to in a little bit of the discussion that we want to have today is the idea of a stable cohort of patients in a provider's office for a period of time such that you can provide an investment and see that investment come to fruition with positive outcomes over time. So thank you, Don, for mentioning exactly that, and thank you, Joe, for leading into that. So we know from an MCO perspective, we've had churn. I haven't looked in a while what our churn was. Last I looked, it was 8-9% of the members that we have, we no longer have. It dropped down probably since the last I looked because unemployment has gone down significantly. So there's a little bit more. We recognize that churn exists, and it's very difficult if you have a churning environment to make those investments to see those outcomes. So that's kind of what we wanted to touch on today, and have a little bit of a conversation related to that and see where it goes. So as way of background, United Healthcare has had a full risk capitated relationship with Northwest Physicians Network for about 5.5 years now. It is a full risk contract where we pay a % of premium. So we delegate services along with that premium. We delegate claims, we delegate utilization management, we delegate complex case management. We also expect under the contract, and NPN certainly delivers, a network of providers that can service patients attributed to NPN. There's a lot of advantages to that model that we can't do with any other provider. Some of those things that we gain a benefit from that is from a very selfish financial perspective, 100% of the premium that we're paying to Northwest Physicians Network is risk, and which means it goes towards those incentive percentages that you saw. We're far right-hand side on the HCP land scale, which is very nice, of course. Northwest Physicians Network also services their providers in a way that makes them very close to them, which allows for a level of flexibility and a level of activity that we can't have with the rest of the network. It's a different relationship when a physician in your network is also sitting on your board. So it allows for that level of flexibility, and that flexibility helps us being able to react. So if there was a question a couple of months ago, can you give me this extra pharmacy data that I didn't have before? I can do that next month's report. So we can react to that where we won't necessarily be able to react to that in that way with any other physician. So it also, when we're having the conversation about value-based contracts, it's very difficult to go to a small independent clinic and push a risk-based contract. It just doesn't work. The denominator is too low. With an aggregator like NPN, all of a sudden you're talking about a much larger denominator, which allows us to be able to move into a value-based world where we wouldn't before. And NPN has specialized in snapping up and supporting independent practices, which I think we touched on in a previous session, the VP Action Team session, that when we get closer and closer to that 90% goal, it's going to be more and more difficult to get independent practices into value-based contracts, and there'll be more and more pressure to either move them to something that that clinic is not ready for, or to push them out, which neither of those are good options. NPN brings the ability for us to be able to support that in those infinite physicians that are so critical to the safety net of the state, that they can thrive. So what we wanted to talk about today a little bit is that stable attribution of membership and the month-to-month churn that we have currently in the state and what sort of what that experience looks like. Is it good for you?
Thank you.
Dr. Crum.
So just by way of level setting too, Northwest Physician Network is an independent practice association of almost 1,100 providers we're in 5 main counties, it's Snohomish, King, Pierce, Kitsap, and now Clark County as well. And our primary care base, 200 plus. In family medicine, you're talking about maybe 10 to 15% Medicaid. You're talking to some of our pediatricians, solo pediatricians who are 70% Medicaid. And as the larger systems tend to shrink their Medicaid exposure, more and more of that is indeed spilling over into the independent community. So one provider that I think about, I really highlight often works in a pretty high risk community, takes care of some really needy folk. Doesn't have a stool in his exam room because he said he can't understand a child until you get down on the floor with them. And he operates a food bank in his clinic. On the extremes. So that's just kind of a base that we are. And because we are full risk and whatnot, and we think about these innovative payment programs, I can't say capitation now, you really got me sanitized from that. It really is, and you got to know who your patients are, right? We want to try to provide integrated care over a period of time to this vulnerable population. You got to kind of know who they are. And recognize that there are swings that naturally happen as people become employed or come on and off the rules, but there seems to be something more in that. And so I just want to share a story with you, a true story from one of our providers who has a panel of about somewhere between 300 and 400 Medicaid patients through NPM. A pretty ethnically diverse, culturally diverse group that's cared for by this provider. And I'm just going to read this to you. This was a summary from our senior business analyst who put this together, who's really chasing down this whole eligibility issue. So I'm just going to read this. It's just a short vignette here. Managing eligibility for the Medicaid population has been quite daunting. In one example, a provider with a panel of 300 to 400 patients experienced a constant flux and churn in his panel. The details show that in 2017, he lost an average of 10% of his panel monthly due to Medicaid terminations and or now in some cases mysterious primary care and MCO reassignments. His panel did grow by 15% from other sources, so he's had a small increase. The small increase, however, masks issues that can only be identified by doing an in-depth analysis, but the providers experience and know well. By the end of 2017, only about a quarter of the patients assigned to him in January were still there at the end of the year. The difficulty in managing Medicaid eligibility sometimes results in complete panel drops. The patient lost almost his entire panel, 308 patients, in December of 2016, but was able to regain 213 of them back in January. This provider's experience is not unique and occurs throughout the network. Providers need to feel empowered to be able to take responsibility for their patients and know that patients will continue to be assigned to them. The constant and large panel changes make it difficult to determine patient assignment and responsibility. And so I did a little, this is all sort of back of the envelope. This is not, scientifically tested data, and maybe it's just measuring different parts of an elephant or something like that, or an iceberg or something. But we have about 12,500, somewhere that, Medicaid patients with our friends at United. And by contrast, we've got about 6,000 Medicare Advantage patients. We estimated, did this just 2 days ago, but we estimate that somewhere from an administrative standpoint, we are investing in 2.5 to 3 FTEs to manage the eligibility on the Medicaid side. We have between 0.5 and 1 managing the Medicare population. So then the question is, so what's different? There are differences in numbers and whatnot, but, one of the things that we keep coming back to, and at least we're scratching our heads about, is the whole issue about the fact that patients can be bounced monthly. They bounce around, there's the eligibility issue that the state has to deal with. There's the issue of the MCOs, is the data for them correct, and then you pass that downstream to the providers. So if you have a physician who's having 300 patient swings in any given month, we had another doc I didn't even talk about here who lost his panel twice in 4 months in this, where patients were mysteriously disappearing and being reassigned to different things. It's the fact that we're going to try to provide, unified care. We're going to have innovative payment models that support longitudinal care. We've got to figure out how that, and when you look at the Medicare Advantage population, in contrast, and again, I know it's not completely apples to apples, we have very little fluctuation in that population, who have to go through an enrollment process where they have to select a plan, they have to select a provider, and they're locked, generally speaking, they're locked in for a 12-month period of time. You know, and so the people that we get on and off the Medicare Advantage rules are people who die, who move, you know, or you know, the new people who just turned 65. And perhaps that, you know, that swing is bigger in the Medicaid population, and I don't have the data to support that. But I just envision a world where our Medicaid people choose a plan, choose an MCO, choose a provider, and they're committed with them for a year, and we have payment models that actually support that at the practice level, then maybe we could actually get to the level, because I presume the goal of this group is to really come up with some recommendations about how are we going to create and fund and pay for, you know, integrated care across the continuum. Yeah, and that also means and John, you were talking about taking behavioral risk. That's a conversation that we just now starting to have as well. Is there a way to bring some of those services back into the tent, where we have our, you know, nurse care managers and all of our other medical management and care management support infrastructure in place to manage these patients. But there are just clearly some administrative head scratchers along the way. Now, Rick, you tried to find out the origin of this month-to-month selection process. It's not CMS driven. It's not. We don't know where.
Other states do it differently. Oregon, of course, they're so far away because it's on the other side of Columbia, right? So it seems to be a convention, maybe started with good intentions at the legislature. I don't know. It seems to be mostly political. There doesn't seem to be anything in the law that would prevent modifying this. And Scott didn't even mention the downstream effects of eligibility with 2.5 to 3 people trying to manage that on a daily and weekly and a monthly basis. Data quality sucks. That's a technical term. And it's a very expensive problem, because now you're dealing with high-paid IT and trained nursing care coordinators and care managers who are very used to working with data quality issues. So they spend a lot of their time tracking down what's true or not true with a person, or trying to track down a person who moved over to another plan. And in truth, we end up supporting lives which are now reassigned to another MCO, because that's the right thing to do. So, you know, I think I'm seeing head nods around the table. Is there anyone who can't identify with this problem? So it seems like, as an action team, we ought to be able to discuss further, maybe bring in some other case examples at the MCO level, at the street level, to begin to come up with formulate recommendations, dimensions of a recommendation that could go forward out of this committee to a larger audience for consideration, because this is expensive.
It's hugely expensive, and I was going to say, Mike, it's probably been the number one issue that's come up with our TCPI team, just working with practices, even who aren't necessarily fully up to VBC yet. The idea of getting synchronized on our patient panels, and I'm not saying this is the only thing that impacts that, but it's a huge problem driver. The fact that patients do move every month and that there is this huge churn makes it really tough when then a practice is trying to truly understand this is my panel, because, like you're saying, it can be in flux on a monthly basis.
Sure.
I think last legislative session, when I was meeting with legislators, I mentioned to one of them that this ability to change every month was, you know, going to be a problem. We're hearing from providers in the early adoption region that it was a challenge. And she said, it has to be that way. And I said, how come? And she said, clients have to have choice. And I said, they don't have to have choice every month.
But AARP seems to be happy with an annual selection process, right?
Well, for our employees at work, for our health-sponsored, you know, insurance, it's open enrollment once a year. You don't get to just screw around every month like that. So, I wasn't sure where the attachment to this monthly opportunity to choose again was coming in. I don't get that, why anybody would defend it really. But what I can tell you is it wreaks havoc with value-based contracting, with committing to clients, with, tracking progress. Say the data gets all screwed up, demographics get all screwed up. So, you know, if there's anything we can do as a group or anybody else can do, as part of the group to relook at that, I'd sure be all in favor of it.
I came from Oregon, where we had an annual period, so I did some research on how you got in Washington to every month, and it is exactly that. It was the advocacy during the time that bill was in place that indicated choice meant that you could, each time you encountered an issue, move to someone else instead of work through whatever that issue was. So it would be incumbent upon us and our circles to redefine choice, and then to be very specific about the protocols when folks are experiencing difficulties, whether it's a provider network that's not meeting their needs, whether it's a particular type of service that isn't being covered. But we could do a lot to just cut down on so much noise by knowing that we have someone in a particular box for at least a year. I mean, insuring people year to year is a hard argument for me. You really want to make investments in people you want to know they're going to be your investment to gain from in the future, but month to month is insane.
There's huge cost and no value.
And we're not even convinced, and I don't have a good feel for that. I mean, I have sort of a subjective feel for this too, that how much of this is actually patients actually exercising this choice versus just the challenge of having this fluctuating population from an administrative perspective, because we have patients who go off the panel who end up in somebody else's MCO, and I don't know if there's that much sophistication amongst a lot of these. A lot of these folks just want to have their primary care doc. And they show up for service, and then they find out they're ineligible. They're not in the portal. They're not wherever they aren't. But I'm not even sure that we have wanton, we have wanton behavior of the covered population and slipping in and out and trying out one plan over the other. I mean, there may be some of that. And I think sometimes the provider community also, in some of the way they, the way they behave and some of the choices they make too, also contribute to this. But if there was just some way to at least quiet, to your point, we quiet the level of basic, get the white noise down, so we actually have a better understanding of what the real issues are and how to go about them. Because I'm sure, I don't know, JD and where you guys are at or whatever, what you're seeing too in terms of the data swings and things you guys see at the state level that you're also trying to manage to only become larger and larger as you move further downstream.
Yeah, and just, the pilots project that we're working on with Northwest Physicians Network and also with Summit Pacific Medical Center is really partially targeting this challenge, but it's also a huge data challenge. Because the Healthcare Authority has all the Apple Health client eligibility data and claims data, but to be able to query that month to month and pull the attributed claims data, we need that attribution or that patient assignment data. And it's not easy to get that from MCOs every month. So just process-wise, there's a lot of challenges to getting that up and running. And this is on a small scale, relatively, thinking of what it would look like to do that statewide. So I don't have an answer of how to best do it, but we're making progress on that small scale.
No, but it's hard. It's tough for you guys too.
It's tough, yeah. Tough. And we have small teams that are charged with doing the data infrastructure build, and I don't know if that capacity we're building would even scale in the near term.
So, Dawn, maybe you've gotten closest to the heartbeat of the original decision-making process. I can fully imagine how that went, because it's one of those feel-good decisions that, as a legislator, might say, well, it's safe. But who in the legislature understands the implications of that decision?
There was a strong advocacy push that and, anytime.
So, it's 2018, Sue Birch is at the helm at the HCA. She's a firebrand. She comes from Colorado, which is a very progressive state. She's made a lot of progress there. She can make a lot of progress here. I think this is an issue that ought to be put in front of her, with us working with her to craft, language, proposals, documentation, making some estimates. I mean, I can imagine a work group could put together, how much does this cost Washington State? I've already said $5 million for everything, every year, that we just blow off because of the administrative inefficiency and the impact that it has on human lives. That's the other side that wasn't considered when this decision was made. This screws up patients. We've heard about that because our nurses deal with it day in and day out. They're confused. They don't get any benefit out of this. So
And would it be helpful, from my ACH standpoint, because I'm very careful not to volunteer my 8 colleagues, but, we do a lot of community engagement at the grassroots level. We have folks that go out into the communities and talk to the actual beneficiaries about these issues. I mean, this could be a great topic to just probe as to, do you value this? Do you see this as a benefit? Do you utilize it? Is this something that if we move to an annual registration for an MCO plan, would that be something you would see someone taking something away from you? Because I think if we got from the advocacy group down to the actual folks who use the plan and actually need every day to understand how to manage their health care, we may see a little bit different of a response to that question.
Yeah, and I think there's one other opportunity, and that is in the eyes of providers, to be able to, to really make the Medicaid population an attractive one to care for, and some money we're not spending on 2.5 or an extra 1.5 FTEs that could go into an incentive program, or something that could stabilize the panels for our providers so that the Medicaid population is an attractive population. And I think as an IPA, what we try to do is we try to stand in the gap for what the marketplace and what our physician is requiring and what our physicians can't do for themselves. And there's a whole lot of things we could be doing with that money besides just, chasing this kind of data, having endless conversations with Alan and, about the same old that we know we could potentially really impact with some policy change.
Is there any sense of what percentage of Medicaid recipients are partial year anyway, would you be institutionalizing a few months of coverage that
2% churn, I believe, in terms of between the plans. So the actual between plan isn't that high. I think more of the churn is on the in and out.
Insurance
eligibility. Although, even 2% isn't a whole lot of time and money and, effort within that population.
Yes, as I've been thinking about it, there's kind of an evaluation context to think of, kind of working up from the primary care provider level. So why would a primary care provider's panel fluctuate? It could be because of choice. It could be because providers encourage patients to move sometimes. I mean, there may be an element of that. It could be because of reassignments based on mobility, although that may not be a big issue. I just don't know for the population.
I totally agree.
And I'm not suggesting that we kind of cloud the objective by getting into niggling detail, but it would be helpful to get a sense of some of those causes. I'm curious from, Scott, you shared things from a provider perspective, and Alan, you did talk about an 8 to 9% churn. Within the MCOs, do you tend to see kind of the same level of fluctuation as what Scott was characterizing? I'm just wondering, are you getting a fair number of folks come on and off your roles based on what I guess would be eligibility numbers?
I'd have to go and get the exact numbers. I have one in my head just because it was mentioned in a meeting I was in yesterday, and I just did a quick calculation, and it was more like 3 or 4%, but that's still a huge volume of deals for us.
Well,
But,
and in 2020,
numbers on on and off every month. I mean, it's a lot of people.
So, and you can help me validate this, but in the year since I've been doing this, I've seen a shift between our two plans in Southwest, a couple of percentage points. And I think we need to look just beyond the percentage points, because let's face it, the people who are moving are the people who are getting care. They're using the system. If you're not utilizing the system, you're certainly not flipping between MCOs every day. So not only is it the numbers, but it's the population that may be moving around that actually is utilizing a large percentage of those services and could be costly, and our inability to actually do a good job of managing those folks is more important to me.
One comment, if there are going to be any changes, one factor should be considered is enrollees that are assigned to a primary care provider, but they are not engaged, and later on we find out that they had expensive hospitalization or specialist visits, and they were going to another primary care provider, even though they were assigned to us. So cases like that needs to be flexible to reassign to wherever they are going for their primary care provider visit.
Yeah, I have two thoughts. One, just in terms of sort of the lobbying question, it may be worth bearing in mind that HCA can't lobby the legislature, we the executive branch, and we do what they tell us to. So there may be other routes that are better for that.
Education is what I was thinking.
But I think that question is a really interesting one, and having sat on the provider side, smashing my head against the wall with this problem, and also the MCO side doing the same thing. Like, attribution is messy, right? Because my patients may go and see Dan Leffler and come back, and they're halfway between, or they've been assigned to me. So I think it's really interesting that you guys have been doing this for 5.5 years through these problems, and I think that even with some of the structural things better, there does need to be kind of a process of hashing that out. You know, who gets, and if I'm getting a PMPM for taking care of someone, at what stage is it my responsibility to draw them in, and at what stage is it like, no, this person is really getting their care with Dan Leffler and not with me, move him over there. So I think, and I don't know if either of you two want to speak to sort of that, how does the hashing out work? Because I think that even under the best of circumstances, there's got to be some of that, of sitting down, is this list right? Look, this person has gone somewhere else and they're not seeing me. Look, this person is not part of my world. Or, yes, this person is not seeing anyone, and I'm going to take it on myself to get them in.
Some of that can happen, but I also have to respect that if I was taking the hardest contract compliance view, and that's the role I'm supposed to take, that there's language in our contract that says that we can't reassign patients to a different PCP unless they ask. Upon initial enrollment, certainly we do. And they might have a completely different reality than what the PCP assignment is in our system. So we've impaneled them. They're not seeing that PCP. They never call us. There does have to be some level of outreach and them engaged in the process of changing. And that if I was to put on my compliance hat, those are the rules that we have surrounding us. We would love to have the flexibility of coming up with a true PCP ability, to be able to say, well, we're seeing based on experience this is happening. But right now, if we see that, we have to engage the member to make a change.
But close would be an improvement. That's the idea. I think that ultimately,
you know, the same issue in spades. It's all of a sudden somebody's on our full risk program. Right? The claims are coming in, but it's from somebody else. And to me, this should be wrapped around. I think one of the first meetings we had, we talked about quality, cost, and patient engagement. And I'm not all for putting restrictions on patients for re-enrolling, but we got to get these patients connected with primary care. We have to find a way of doing that. Getting them out of the ED, getting them connected. How do you do that?
I would just add, we have, I know in our world, only 9 or 6% of our Medicaid clients choose their PCP up front. So 90% of them are going through an assignment algorithm, and then through, the process of where they actually land, maybe they get to where they wanted to be. But it's that engagement up front and having, I think you mentioned Dr. Carlin about in Medicare, folks choose that provider up front. I mean, that would be huge, rather than having it default to an assignment algorithm.
It'd be nice to understand how this actually works. That's an amazing number, that only 6%.
Yeah, that is.
This is complicated. We always kind of wonder, well, how did this happen?
So this is a great table. I mean, all of a sudden, we've got lots of good input coming in here. Maybe we need to create a work group that looks just at this issue to make sure that we're not overlooking or oversimplifying a dimension of the problem. Even if it's 3 or 4%, we're looking at administrative efficiency. Something that's 6 in micro, and then one more is a provider in the NPN network who twice had a panel disappear, just like that. That's administrative on it. It has something to do in the food chain of handling data administratively. This is a human problem. The more times you do that in a year, you're upping the ante for errors. That's a simple. One more.
Just from what I've seen and heard, I think we may have more of a problem, less of a problem here of traditional churn, where you have people popping in and out of a plan, versus what was discussed earlier, which is you've got a population that just isn't, for the large part, familiar or comfortable with dealing with a managed care environment or a healthcare period. So the idea of even what is a primary care provider, what are you asking me? For a lot of these people, this is just not something that they understand. So it's a very different population in terms of their experience that you would have with a Medicare Advantage plan, which is probably those people have already been involved in managed care for most of their lives. So you've got a different challenge here. And this really kind of dovetails with the regulatory issue we talked about before. I think we need to understand where the monthly piece comes from. I hear the same concern across multiple states. And this is whether it is embedded in federal rule in truth or whether it's a truism, you do see it living in state Medicaid state plan amendments. And so if we want to change this, which I think we do, you've got to figure out how to work through that regulatory environment. Certainly for whatever people may think about the current CMS and their policy right now, it is becoming easier to have certain types of state waivers change state plan amendments. They have things like prospective enrollment going on right now where you can actually assign people up front. Things where you can move people from a Medicaid plan because they become employees, moving into an exchange plan or other plan. There are ways to be able to manage that more efficiently. But you're going to need to have probably a state plan amendment to do that. So if we put together a group, I think that's something you have to look at our own state plan amendment to say, is it in there? And maybe we put it in there because we wanted to, or was that a requirement? But CMS approved that. The changes, you're going to have to go back to CMS and have them change it. And then what are the sorts of changes we want to make to our state plan amendment? Because that's how you go about practically doing this. And what are the options that CMS has out there for us right now? And there are some that I think would be useful to look at.
Great comments. And I wonder if there isn't an ACH role in this. Dawn was kind of alluding to that. This is kind of the work you do. And if that were done consistently at the ACH level, from the patient enrollee perspective, you're closer to the pavement at the ACH level. You might be able to make better traction through education and helping people to connect with providers that are well matched to their needs. So I'm trying to beat the clock here. Chase is going to be up next, but we did promise you a little break here, and maybe 5 or 10 minutes, and come on back, and we'll just get on it.
Hey, how are you? Good to hear you.
I was on for the first hour. Yeah.
The problem is hard for the Medicaid side,
Oh, so you're the one watching this?
We're not down there.
They're not down there. I know, but you're not contracting on it. Okay, so after that, I thought we were dealing with the group, but not at the ICA level.
Right.
Okay. I got it. Okay, that's what okay. Well.
So,
You're opening it up to it,
They'll get maintenance in the plan saying you're assigned to Dr.
Good, how about yourself?
No, I'll just spend the night and eat today and tomorrow morning. Except for in our account. Yeah, we have cars.
you know, the challenge, the risk is trying to study this thing to death.
Yeah, I know, and that's what I was, like, I was
Not at all. You're right. I think there's like the challenge because we gotta, yeah, I'm not suggesting it doesn't, but the point is there's so many, there are so many simultaneous variables. Doesn't work.
Yeah.
So. Say, let's go to annual, and also, election.
Right.
Population itself is so volatile. Think about the eligibility, and I think it's only going to get worse with the president. Right, what, right?
Yeah, well, we're, honors and, it's 100. What's the cap rate, $140?
You also put in notice but we can get a three-way commitment. The question would be how much administrative burden you need to actually get that, that are otherwise staff.
But,
second sort of back in the right. Okay. Well, taxation answer. At the end of the day, I think a lot of our docs are heavily invested in the Medicaid population. Most of the Richmond population. But the notion of saying we gotta have to take care of these people anyway. Why don't we do it in an aggregated fashion where we it's a meeting and our own shot. Right. And we can build an infrastructure. Yeah, so I'm not used to this. Because we're also going to tell them we're going to support you.
Yeah, that's
So the question is, from a chicken and egg perspective, first I don't know, but, how do we take it down to at least something? And I like your idea that, data is part of that, but to do it, it's freaking get a few ways of it. Provider community, their community, state, do it. See what happens. I mean, you don't get always go back to it. Or certain services. Otherwise, you won't recognize. That's important. That's why I just want to do a data argument.
Oh, no, it was, right.
Yeah, Tuesday, not on March 16th.
Oh, maybe I can't write an analysis very well. What if we just write some of the language? Maybe either from
Actually, the real reason for the slide was we just wanted to show that there are two spellings of Fisher, and that was the only.
Yeah. On the same slide.
On the same slide.
But I had to make sure that JD at least had something to say, because we kind of forgot about him. Great conversation.
Right.
Well, everybody in the room, to reconvene. We will be adjourning at 4, no later than 4 o'clock. So our last session, I think, is important to get going. Laurel and Terry. Great. All right, I think this is, we have peeled off maybe 1 or 2 people for other commitments, but Chase, why don't you take it away?
Sounds good. All right, so it's just going to be a couple minutes of framing, but then we really just want to have a discussion with all of you. And to be clear, we're pretty ambitious. We actually want to get some direction today on some principles that we can take to an ACH meeting next week. There's an ACH convening, and we're going to have a conversation around VBP and the ACH role and how the Medicaid transformation effort fits in that. And we realize we have an opportunity to do some framing that could be really helpful as we get really tactical and we get really specific on how to use resources, how to identify providers and pick specific strategies. We think there's a good opportunity for this group as an action team to provide some recommendations. So we're not going to be revising today and agreeing on a final list of anything, but it's more so just a discussion. We're going to take notes and we're going to use that to guide the conversation with our all the ACH partners next week, and some of you are probably going to be in that conversation as well. So the reason we're talking about the need for VBP principles to support ACHs is really because, as JD talked about, the HCP land framework and the categories of VBP and our movement along that continuum, these targets are attached to our special terms and conditions under our Medicaid transformation demonstration. And maybe we don't talk about that as much, but it's really important because it means we have statewide accountability to these results and funding attached to those. And also, there's a lot of emphasis on VBP as a foundational part of the Medicaid transformation work. There's Domain 1, we've all been in discussions about that. One of those Domain 1 categories is VBP, and it's not a separate thing. It's not a project. It's really that VBP is the North Star, and the resources and the transformation activities of the demonstration can move us into that realm and support providers and support the arrangements that MCOs already are working towards and expanding. So we wanted to just elevate the importance of VBP and the framing that this really is where we're going, and we have a great resource to get there, but I think we need more discussion around what do the ACHs do to support what is in scope, what is out of scope, what is clearly the MCO to provider relationship, what is clearly the ACH as a partnership and as a convener, what is the ACH opportunity. So today we're going to spend most time discussing, and in a minute we'll show you some principles that we pulled. Kaylee's going to go over some of that detail, and basically it's principles that ACHs go forward in their project plan. So here's how we're thinking about VBP. When we engage our partners, when we select projects, when we move into implementation planning, this is what we are thinking about regarding VBP. And you'll see some variations, different approaches to how ACHs think about VBP. And then we're also going to, if we have time, get to some practical, tactical examples of what does that mean when we're paying for services? What does that mean when we're contracting with providers through the Medicaid transformation resources, when we're using those incentive payments, when we're selecting specific models? How are we talking to MCOs or not talking to MCOs about that and about alignment? So different, really tactical examples. And so not to, principles sound maybe a little bit loose or a little bit theoretical, but really we're talking about principles because it's hard to get to practically what do we do with dollars and practically what do we do with partnering providers that are at our table if we don't have a consistent framework to just kind of map out those roles between MCO, ACH, provider, and establish almost some, just ground rules of how we think about VBP and ACH support. So we quickly want to go from principles to really tactical, but, we don't want to skip over the first part. So, yeah.
I want to just turn that a little bit on its head, just to wax philosophical for 1 second. That I think the reason that it is built in as such a fundamental part is because we think it is the way that transformation is going to be achieved and sustained. So I don't want to have anyone leave here with the impression that we have to get to EET because we've got money on it. But we put a lot of money on it because we think that it's the way to sustain a transformation.
So yeah, so as we think about all of the ACH projects and the activities that they're going to be supporting, thinking about how EET is ultimately the future of those transformative activities that make a lot of sense. And that's exactly the kind of framing we want to talk about to see, are we all thinking about this in the same way? So let's go through, I'm going to turn it over to Kaylee, see if I missed anything, and then maybe you can talk about some of the principles to start with. And then we're going to just have some discussion to see what resonates, what doesn't. You know, is this what you've been thinking about? And how can we further that conversation with ACH? Yeah. So we have a handout that's hard to read. So we'll pass that around, and Kaylee, you can go ahead.
Yeah. So I'll just repeat. So we're going to start by talking about guiding principles today, and I think where we would like to see this conversation to go in future meetings today is really kind of to what end. So we've got these principles, sort of now what are we as a state, and what can we offer recommendations for our ACH partners as they really do that work within their communities. How are they defining success for their region and for their partnering providers? And how do we do that also in a way where we're providing some of that statewide direction, again, kind of the purpose of why we are all here as the MCT action is to make sure that things that we can offer are some recommendations that may apply across the board as opposed to trying to figure out this work in 9 different regions. So, and again, I think a lot of this work has already been done by the regions, but I think what we're trying to do is just take a step back and see what are we seeing across the 9 ACHs, and as an action team, can we just provide some more statewide recommendations for those that maybe haven't necessarily had this conversation. I also don't want to, this is not to replace anything that ACHs have already done. I think, and what would be also, I think, helpful is to hear from some of you who have had these conversations with your ACH and how you're using guiding principles, because again, this is pulled right from ACH project plans. So these conversations are happening, though not everybody is really kind of attaching or identifying them perhaps as a guiding principle. So this was some of my interpretation, I guess I would say, of through those project plans, kind of what we're seeing as themes across the board. And so again, I think we'll be taking notes. Our goal here is to look at these and say, as an action team, do we think this is a good guiding principle that we would offer as a recommendation for all of our ACHs to consider? Are there things that are missing, other discussion points that we need to have? Again, thinking about how do these then lead to what is a definition of success, and how does that then relate to the projects that ACHs are doing with their partnering providers? How are they using those guiding principles to think about the gaps or technical assistance that may be needed to help providers really move along that value-based continuum? So again, I'm not going to read these to you, but these are pulled from project plans, just from all 9 ACHs. Some of them are a copy and paste, or just something that was slightly refined just because we saw really similar things across some of the project plans. So I don't know if we just want to take 30 seconds to read through, and then I think particularly if there's anybody who would want to share just how this is working within your ACH, if you've had really the guiding principles conversation, and how that's impacting kind of the next steps that you're taking to actually start to get a little below the sort of conceptual and the theoretical, and really how that turns into action to support providers and making sure that we're hitting those goals that we set out to ensure that we're sustaining transformation, and also because there's dollars attached.
and they ring true with how people are behaving and what people are thinking about at the county level, as the ACH matures and staff are being hired to fill gaps and needs for ACH activities. I think these are nice sensitivities or reminders of, what everybody needs to be thinking about. And then you put it aside, and then you try to figure out real problems. And that's where my head immediately goes after reading the list. I didn't see anything from the Pierce County perspective that is glaringly missing or in conflict with behavior that's been shown so far. But there are some really, really naughty issues. We talked about eligibility as having so many facets, right, and complex, yes it is. But sharing data is a huge problem. Sharing data is going to bring us all to our knees unless we come up with a solution that works across ACHs, within ACHs, and in support of what we're trying to achieve. Is it an HIE or not is an open question. But people are running businesses on the delivery side, whether it's behavioral health or hospital systems or independent clinics, they're trying to survive economically. And sharing data through an ACH lens is not high up on the list in terms of budget. Everybody wants it to happen, but how's it going to be done? So that's one. Another one is sufficient funds in behavioral health so that when integrated payment occurs, people don't go out of business. It's a big issue that gets talked about a lot in Pierce County. Pierce County may be an outlier in the Medicaid population. I don't know, but I doubt it. So those are two big ticket items that get talked about weekly, daily at the county level.
So I guess, how do we turn that into some principle that can then be actionable? So trying to take us, yes, there are a lot of challenges, but listing the behavioral health funding example, is there a principle then that we could apply so that we don't lose sight of that? So it's kind of some part of a framework that we've acknowledged it as something that needs to be considered as we move forward.
I'm going to say one thing and then I'll be quiet. But one thing that I'm concerned about, and we lived it out in Pierce County between the transition of activity from the health department early on, going back a few years ago, to an independent 501c3 ACH. So now a question that lurks in the back rooms of meetings is, so what is the ACH going to be? What's it going to become? Is it going to become another health department type bureaucracy? Is it really going to be there to serve the community and all of its constituencies in a very even-handed way? Is it really going to be a community resource? Or is it going to become its own institutional silo of activity that has its community favorites, as it were? It's a big question. It's a human problem, and I think that doesn't quite reach us.
One place that I can envision sort of fitting this into a principle is in that area of the barriers and enablers, because that's sort of, I mean, some of that is, right, barrier number one is data, and barrier number two is attribution. And I think we've sort of heard those things over and over again. And as the ACHs are thinking about what can they do to make this all possible, to make it work, if we kind of call out having a really active role in solving those fundamental problems, that's maybe a little stronger than what, maybe stronger than what we have here. Does that bring it in? I think that if you read the project plans, everybody gets that DBP is really important.
Sure.
Some of them are sort of in a, like, we'll make a bundle around a particular thing, or sort of more in the, well, we're going to be doing DBP with our providers, which probably everybody is to some extent or another. And others are really thinking more about how do we facilitate the FCOs and the providers into getting to DBP. And I think sort of some help from this group as far as what's that vision of the role that the ACHs are playing in helping. And I think you're absolutely right that having a real and deep understanding of those huge barriers and throwing it,
Well, it helps define the role of the ACH, and that reverts to principle.
Yeah.
So if the ACH is more of a verb than a noun, in terms of the construction of activity, a force in the community or in the ACH, then I think the principles, you can tie to the principles pretty actively, to be able to, so what is the role of the ACH and its partners, as it were, to overcome formidable barriers that are very difficult to solve in isolation, because they're complex. They require all sectors to weigh in on it. Our eligibility / attribution is a good example of that. So if the ACHs are all clear, then we can expect hard rowing from each of the 9 ACHs across the state toward very common functions at those levels, which is respective to and responsive to the diversity that is represented across those ACHs.
I love that image because I'm sort of thinking of that as being what we're all doing here is sort of helping to get everybody growing.
Well, yeah. Trying to get there.
In one sense, there's almost a need, perhaps, to state as an assumption, or perhaps state as that the ACHs can influence the movement toward value-based payment. And so first of all, I think we all have to believe that that's true, that that's possible. The ACHs can influence it. Having said that, then, perhaps the way to approach this is to say, and the ACHs can exert that influence by fill in the blank. By moral suasion, by, and I'm going to throw this out just as a bombshell, by direct contracting, but you know, I mean, there may be, and I think there are some elements of that embedded in these principle statements. There's that first sub-bullet, the ACH must set expectations and criteria for performance as it relates to this in line with MCS. So there may be a series of those blanks that can be filled in to describe how the ACH is going to exert that influence. And the statement coming from this group, back to the convening next week, that this group does believe that the ACHs can exert some influence in this regard. And if you don't think that's the case, then maybe we should be having that discussion.
So, it may be embedded here, but I want, this seems like a scarce resource question, and to the degree that you have $1 or an hour, what are we going to spend our time and money on? And so to the degree that the ACHs can influence the priority of how investments are made, or how what are the areas that we're going to focus on collaboration, that prioritization role is really clear. Then to me, that becomes a platform that you can then begin to, okay, well, we believe say HIE is the most important thing we need to work on, and what's the next enabling step?
So something we struggle with locally at our ACH is that we tend to talk about it very high level and lump everything under one umbrella, but how an ACH would influence value-based contracting really depends on, are we talking about a small provider? Are we talking about a system? Or, you know, what your activities would be, how you're going to approach that can run the gamut from, you know, they got it, they're doing it, they don't need anything, to, I don't even know what these words mean, I'm still trying to figure out how to, you know, get my electronic health record to work. So I think it can, in some instances, be helpful to do that generalized high-level vision piece, but where the rubber hits the road is how can the ACH break up what they're doing to meet the needs of their specific partners across their specific regions. And it does get a little tricky when you start to think about it that way, because not everybody's going to be similarly situated.
Yeah. Is there a way to encompass that as a principle, though? Like that there is going to be that
need for customization and individualization to provide services based on the the specific needs of partners region by region. So it's hard to just say, oh, we're gonna do X, because X may work for a third of your folks, but be useless to the other two-thirds.
So we've actually dealt with this more on a nitty-gritty end, down in the third. The ACH, to us, the primary guiding principle is to be a convener, bring folks from across different regions and to work collaboratively. But the bottom line is that we were having discussions that the ACHs are essentially the equivalent of a burn phone. I mean, we're gonna use them, they're gonna help us communicate, but then they have a lifespan, they're gonna be disposed of. Because how are you going to continue to carry an ACH beyond the Medicaid component? Who's gonna pay for that? Are the MCOs gonna pay for it? Nah, I didn't hear that. Am I gonna pay for that? I don't know. So we talked about possibly we'll set up a sort of like a buy-in system of all the different people that are convened that will support the ACH, but I don't see, once the funding goes away, it's just like the burn phone, man, you're gonna throw it away, because how the hell are you gonna continue to support it? So that's what we struggle with. We just show us the money that this is gonna go on for the next 10 years, 5 years, beyond transformation project. I don't see it. Am I missing it? Budget? No, I'm not, okay.
I mean, I think different ACHs have a very different vision of that, and some of them don't plan to, and some of them do plan to, but in a really different form that isn't about what do you do with district funds, but about, you know, we're gonna build this role in the community, and here's what it's, I think it's a huge question. I'm not sure it's in scope here, but I think it's a huge, yeah.
Did they express how they're gonna pay for it? How are they going to sustain it?
I think it is an important question because it changes how we relate. If you're relating to something that's temporary, potentially, and how they intersect and how integrated they are into the work you're doing, versus something that's maybe more long-term, that's it, for me, at least, I think that's a different relationship. Because I think the challenge is that I look at some of these things and I go, you know, contracting, provider contracting, to address barriers and promote enablers. What does that mean? Because from a practical standpoint in negotiations, I don't see the role necessarily. I see the role in terms of standardizing quality metrics and some of the help across horizontally, but not so much vertically in terms of dealing with one-on-one.
I mean, the ACH isn't gonna get in my way of contracting, just like, I mean, the state right now has gotten in my way of contracting with, MCO, and I'm having difficulties there, and so, I mean, the bottom line is our agency, our services, our resources, and to think that somebody else is gonna intervene on that in that capacity. I mean, I just have, unless, I don't know, maybe I'm just being overprotective on that end.
Can I give an example just as, so something like, you know, if a provider needs to be able to, you know, small provider needs to be able to have a registry, you always sort of need registry capability to be able to do the EVP. Lots of providers don't have that. So if an ACH could provide a role of saying, we're going to either fund you to get that registry, or we're gonna set up some model registries and give people access to them. A small but very concrete example, like that kind of thing is addressing a barrier and being an enabler that would be potentially temporary, because once you've got that, you run with it and you fund that continued investment through your contract, but you need something to get to that set of abilities.
That makes sense.
So connecting some of these threads, for sustainability, there has to be value, and there has to be some sort of resource to sustain that value. You have to prove the value before the sustaining issue sort of hits you against the wall. It could be tithing, it could be, you know, taxing, whatever you want to call it, a way to do it, and that's probably viable if you're getting more in return in the basic service. So it could be, registries is a very concrete example. It could be an HIE, but the HIE is only useful if it then is the same HIE structure across the state, across all 9 ACHs. So I think this is where it gets pretty expansive in our thinking, because you know, we've been struggling. There are no new issues at the table. It's how we're packaging them and how we're parceling them down to the local level. The local level has to experience value. And right now, it seems like the twin energies at the county level, in my perspective, is the hope for a reduction in administrative burden through collective discussion and simplification and streamlining. Daunting job, particularly when you think about housing and jobs and jails and EMS and hospital systems and independent clinics and so on. But people aren't walking away from the table on that one. But out of those discussions, if we can end up with a way of doing business facilitated by the ACH convening process that ends up in tangible, ongoing business value. I mean, everybody's looking for business value here. Everybody's trying to trim their overhead. Is data sharing a good place to land? Is it something else, or a combination of things? I think that's where my head goes when the principles are nice, but if they direct toward very concrete, business-based issues that are going to confer more access to resources for more people at the ACH level, people aren't going to walk away from that.
There is an ACH that's done that, which I think is hopefully where this conversation will eventually get to. Past the point of principles, this ACH has gathered a variety of groups from their individual sectors together, identified a set of principles, some of which are on here, and used those principles to then drive a conversation of what does success at the end of the day look like for providers and practices to operate in a value-based environment. Not what does success look like under the demonstration, not what does success look like for the ACH, and not anywhere close to sustainability, but what is success in a value-based environment? How do individual providers define that, and then how do those networks of providers that may work at different organizations but work really closely with one another, how are they defining it? And those success, the pillars of success or whatever they're called, then allow these groups to do assessments on where they see themselves in relation to that success and build a plan for where they think they can be at the end of the demonstration, 5 years after the demonstration. And that sets the tone for their individual change plans that then have the demonstration projects and the elements of Initiative 1, like workforce and HIT and value-based purchasing built up into it. So at the end of the day, everything is driving towards EVP, but it's defined and grounded in individual provider and collective group change plans. That's where I see that this could go from a statewide perspective.
Is that ACH anonymous?
It's Olympic. Yep. It's a 3-county region that I think has done a really good job so far, and I think other ACHs, I don't know how familiar they are with the work that group has done, but it's been I think a challenge. I think at the beginning for us to get to a point of defining what this means, but I see it as an ACH that will probably get there at the end of all of it.
Is there something that this group could learn from the director of that ACH?
Yeah, I think that's part of this. It's understanding where we all see as a group of multiple organizations all interested in value-based purchasing at the end of the day, and the success of our providers and our partners and ultimately our members in that environment. And do we gut check agree with these? And if we do, as a system, how will we check back on these with every action that we take at every level of our organization to then ultimately get to that end goal of success for us?
So I guess my question really was, how can we make this more palatable here? It's too easy to get very vague around this table.
Yes.
Too conceptual. And I think we all come from very practical experiences. How do we get more of that thinking that you're describing to bring the principles? Does anybody disagree with these principles, by the way? Bring it down closer to the concrete.
Well, it's the constant battle of, I call it the whiteboard versus reality. We can draw these fabulous diagrams and hook all these things up on the whiteboard, but then when we actually roll it out to the partner, everyone sits around the table when we're whiteboarding and sings Kumbaya, and we all walk out of there feeling great, And the minute we actually then try to push and say, okay, partner A, you're now ready to take that step, either it costs you money or your internal staff isn't all on board with what you agreed to while you sat at the kumbaya table at the planning session. It's that constant iterative move of taking what's the plan and bringing it down to reality on the ground with the partners who actually have to do the work and have to foot the bill. That, you know, the principles are nice to guide the mindset, but at the end of the day, we still have to figure out how to make it possible for people to afford to make these changes and not go broke. And we have to figure out how to not burden them with models that are either not aligned or even worse, in conflict with all of their other systems that they've got to meet for Medicare and for commercial and for meaningful use and for MIPS, and I mean the acronyms go on. So, you know, I get a little tired of looking at principles because I've got partners who are all over, you know, whiteboarding and then keep hitting the wall when we try to get it into place. Hopefully some dollars will ease that, but, you know, spending time on principles versus cold hard solutions gets a little frustrating.
So for those of you who are being quiet, what are you thinking?
I think we started the meeting out really saying last year was more conceptual, and we do need to get into case studies and real examples. And, you know, having an example of what Olympic did is important. And, you know, seeing this list, I guess I never even contemplated our ACH having any type of role or influence over contracting. However, boy, if everyone around that ACH table said, we think this is important, and we think that the NCOs should put this into our contracts in this region, I think that's fine. As an example, but I'll be honest, that's where I struggle, is I've been good about sharing information after our meetings, but it's been difficult to connect dots.
Everybody would notice change the slide here. And this may get right to what you were talking about too. And this is, I mean, so this one actually moves from principles to practical applications, also derived from what we've heard from ACH.
And there are multiple layers beneath this. I mean, I think still you could say this is still high level, or some of these are still high level, but I think this shows why we're talking about principles, and I agree. I mean, it'd be great if we could all say, yes, principles are good enough, you know, we generally agree, but let's just work on the actual problem. And this, I think, doesn't represent a problem, but it does show there's variation in thinking, and that these are both from ACH examples of what they consider to be kind of the practical, whether there were principles or not, but working back from here and working back from ultimately how are dollars used, you know, money's going to go, thinking just short-term ACH role. They have a role to make decisions and to convene and to design projects and to design incentive payment arrangements with providers. So thinking of even that, you know, just box that short-term role within Medicaid transformation and the resource and see some of these examples. That's what we're trying to get to, is what kind of guidance or guardrails would this group offer. And then we could get into something more practical, like we think the change plan idea is great. I mean, I think it'd be a bit much to say that every ACH is going to fit within Olympic approach, but we could talk about what's the right balance to leverage that example.
Yes, but what we're thinking, I worry that the ACH construct limits our thinking. Because, so an HIE by itself really commands the idea that it's broad and it's regional, and rather than an ACH region, but large swaths of geography And then I think where the ACH could have a specific role would be, how do you tie into that last mile problem? Because I think that's an interesting one, where subsidies make sense. So I just worry that it limits our thinking, because if I'm an ACH, I'm gonna have a budget, and I'm gonna spend it in my locale, and I'm not gonna think about a statewide initiative necessarily. That would be my worst case scenario.
As usual, Tom has helped me galvanize my own thinking on this. I think that's a great point. You know, when I look at these up here, I'm looking at it and saying, gee, that looks exactly like what we came up with our own whiteboarding experience 2 years ago, 3 years ago. And since then, we've been trying to work on how do we move this along. And, you know, it's not easy. And we keep bumping up against our heads against those things which are really largely beyond our control. And we can have conversations with ACOs about it, but, you know, a lot of stuff is beyond their control. And that, frankly, is what I'm hoping this group is going to tackle, is identifying those things that are across ACH, across regions, across providers, that we just can't tackle on our own. It needs bigger thinking, it needs bigger solutions. And maybe at the end we say, okay, the ACH is going to put some money in, the state's going to put some money in, we're going to change some state rules and regulations to make this happen. Maybe it's a new state plan amendment, what it is. But those are all those things that are really, we keep, in our thinking, butting up against. And HIE, IT backbone is certainly right at the top of the list. So that's what I was hoping with this group around the table was going to tackle, is those bigger issues that the ACHs on the road can't handle. And we need to have good joint thinking on this. We need to do some prioritization, because the list is long, the cash is slim, and figure out what we're going to do. And then if we have
We have one or two things that we know would add value and would promote systems to pay for that in the long run to sustain this. So that to me has a lot of interesting possibility.
Can I ask a question? Is there any way anyone in this room sees accomplishing true value-based payment and contracting, especially meeting the goals that the state is seeking to meet, without interoperability, connectivity, and better data sharing? I mean, does anyone see even having a prayer of going down this road without solving those three problems, or having some path to solving those three problems?
The only addendum I would make is that HIEs are a bit like EMRs. They're viewed as a silver bullet. I think the process will include defining down, honing down the limited amount of data that are actually...
Interoperability, not HIE.
Yes.
That's very different.
Keep going.
Interoperability, so
yes.
we get basic information flowing between the providers we're trying to integrate so they can care for a single patient. You know, that's all that I'm talking about. But if we can't do that, and we can't share data, and we can't get connectivity for people to connect to things, I don't see how we work on anything else.
Just as a sidebar, how many of you, raise your hands, are familiar with pre-manage? Hey, this is good. Okay. How many are you doing pre-manage? How many of you are doing pre-manage? Okay. We have a solution that's out there. And for those who are using it, how many of you would say you're going to continue to use it because you find it valuable? So, part of the discussion. So I'm going to go out on a limb, and I know I'm talking a lot today as the chair, but I can't help it. So would it be useful? The directors of the ACH get together, what, monthly?
Next week.
Next week? Yeah. Well, anyway, could a meeting happen where all of the ACH directors in the state meet with this group? And we talk through a face-to-face interaction of what's burning on your platter, what is in your road for making sustainable success in your ACH in the future. Have that in the background as wallpaper.
Can I make a suggestion? I think it's a great suggestion. Can I, from a timing perspective, make a suggestion? We are all right now doing the next step I assume, I am, but given the deliverable date, I have to assume everybody's going down this path
Right.
of assessing our likely partnering providers. I think that it really would be much more meaningful to have that conversation after all of the ACHs have a better idea of current state gaps, what needs, really where their folks are. I think that would be a great time for that conversation. I would have concerns doing it before those assessments, that we have a lot of, I think, or I've heard, but not the actual cold hard data we'd want to be using to formulate those conclusions.
I think there's a roles or responsibilities thing that's fuzzy to me still. So there's a role for the provider in transformation. There's a role for the MCO in transformation. There's probably a role for the ACH in transformation. And then there might be something for this group to take off of one of those three plates for transformation. It'd be nice to the extent possible, clearly define. So I know I'm not doing that because you're doing it, or I'm gifting you that problem because it's a statewide problem you said it's to solve. And that might also put some boundaries on where we get into collusion or contracting to make sure that we're all clearly defined on what we can and can't do. But that roles and responsibilities thing and making it universal understanding seems to be kind of helpful. There's some things on here that are awesome if the ACH is going to do. If they're going to supply capital, that's great. If that means it's something that we don't do or something that we don't ask somebody else to do. So just getting some of those things nailed down in this process would be very helpful.
Something you do less of. I'm not taking it.
So, I get at that though, and, you know, again, part of why we're putting this up here is, again, to tell you what is in all 9 ACH project plans. So, is this group responsible for actually telling the ACHs, here's what we are going to be discussing, here's what we are going to provide you within some set time? So do we have those 1 or 2 topic areas that the discussion belongs more with this group, and maybe we're missing a couple key partners that we need to bring in. But at some point, I think I don't think we've offered the ACHs any clear direction of what this group is doing.
Right.
And I'm putting that on the responsibility now of all of us sitting on this table, that it's not for the exact roles and responsibilities. They don't know what we're doing. We don't know what we're doing or what they're doing. And so the point of bringing this group together is to have the expertise and to be able to look across those problems that we're seeing all over the place. So I guess I would push on all of us to try to get concrete ourselves as to what we are going to accomplish.
That's why I think it's a very good, thoughtful process to define roles and responsibilities and hand things off to a different group. If we're making that handoff, so one person knows I don't need to do that, and the other person knows I accept the responsibility for it. In this case, groups.
Great job.
Yeah, this goes back to the question. Is the question, what are we doing as this group? Who are we serving, and what are we taking off of whose plate? Or is it also helping all of those parties figure out what's on their plate versus what's on their plate?
For me, the ACHs probably all have a different idea of what their scope is, and I'm not 100% sure what our scope is at this table. But I think I have a really good idea of what United Healthcare scope is, and I'm pretty sure I know what the provider scope is up until the point that I know that there's capital needed for transformation. Is that moment or that realm of uncertainty that I can't remember who said about during transformation that has to get addressed? I'm not sure where that happens. I know with some of the groups I do. But if we all understood that, including the ACHs, I think it would take us a long way, and it would help define the role of this group.
So timely, because the original HCA charter for the MVP action team is getting a little dusty. It's more than a year old. Well, it's about a year old. And so I think it really is a great time. This conversation is a great time to review that charter. It needs to be modified because our conversation has changed our world and our understanding of it. And together with the ACHs, and I agree with you, Dawn, on the business of post-assessment. We ought to plan a summit, I think. But that has to be a very carefully planned summit so that we use that limited limited amount of time together, really pushing the ball forward and coming up with some very tangible conclusions. Time well spent.
I think you would find that if you polled each ACH, that you do come up with some overlap and some joint vision, but there is subtlety to how each ACH sees its role in VBP, running a spectrum from, I'm still confused how I'm even supposed to deal with this because I'm not allowed to get involved between the MCOs and the providers, all the way to the other end, which is, I'm going to sit right here and I'm going to help everybody figure this out, and probably the both somewhere in between. In Southwest, we've always viewed our role as, if you're in current state and you want to go to this state, there's going to be a path. And the ACH is that financial safety net to get there. Because to go from point A to point B, people are going to be out of money, they're going to have to make expenditures, they're going to have to make shifts. Any way you look at it, it is going to impact our clinical providers' business models and revenue streams. We cannot expect to be successful if they are not at least attempted to be made somewhat whole in that. And so how the ACH will then use these funds needs to ensure that that safety net is being created, whether it's direct payments to providers to compensate for lost income, it can be actually purchasing the services, training, coaching, quality improvement needs, technology needs outright so that they're not expenses for the providers, and listening to what the other needs emerge, but trying to use those dollars not to enrich anyone, but to keep them whole. I can't say that that's shared by all of my colleagues. We've never had that level of conversation, but just as one perspective to think about how the ACH becomes that safety net to allow for that transition over the 5-year period.
So
Don, I mean, that's really, when you look at the underlying, what underpins NPM, that's what we're trying to do. But I think, and so the question is one of the roles or potential role as an aggregator and be able to provide support. So one of the things when I look on some of the recommendations of the methodologic, and I guess that by nature I am a conceptual whiteboard person. Rick and I spent hours and hours at the whiteboard and tried to then implement things from the whiteboard in practical sense that failed miserably. So some of them. But here's the approach that I've learned in my 10 years of hanging around with this independent community. Maybe it's just unique to the independent community. We don't have people that can take time off from work to go to meetings, to be part of cohorts, to be part of these planning things, to re-engineer the world. We've taken much more as a bottom-up approach around, practice transformation. The fundamental practice transformation is you have responsibility for patients you don't see to the same level you have the patients you do see. And so, evidence-based medicine conversations to me are like, does it make sense that patients with diabetes should probably get their A1C checked every once in a while? Does it make sense they should probably get an eye? And all providers will say, of course that's right. That's all. We don't have to prove that. And I said, well, what if I brought you a list once a month of patients who needed one of these things done? Who on your staff would we work with to develop a customized workflow for you that will work for you? Because a big practice may have a care coordinator, a small practice may have a receptionist. And yet at the end of the day, what we really want is behavior change. We want to think that there's a population of people who have needs and now there's a way to meet. And then as an aggregator, we also do telephone outreach to patients on behalf of providers. We do all kinds of grassroots kinds of support so that at the end of the day, what I'm hoping is the provider will wake up one day and say, oh my gosh, this is population health? As opposed to us trying to diagram the dickens out of this stuff, hold workshops, hold all kinds of, well-intended, well-meaning things. But at the end of the day, what we really want is behavior change. And I remember a fundamental principle in when I had my limited family therapy training when I was in residency was the difference between insight and behavior change. So we around this table tend to be people who change our behavior based upon the insight we obtain. But a large portion of the population, including the professional population, doesn't necessarily do that. They experience it from the bottom up and then say, oh, so that's population health? Yeah, that's it. Oh, well, that was easy. So I think we have to be careful that we don't overly make these so academic and so conceptual, and then beat our heads to death saying, where are the docs? Where are the providers? We're having all these meetings. We're holding these seminars. We're having all these workshops. Where are they? As opposed to using those resources to just enable them from the grass from the bottom up about how they could be more successful. And at the end of the day, with the appropriate kind of incentive plans, like Mike talked about, and we're rolling out some incentives around Medicare Advantage and things like that to try to encourage people around star ratings and things like that. It's the same idea. Is what's the role of the aggregator in enabling those people to be successful? And sometimes that's in spite of themselves, until such a point in time when they wake up one morning and say, oh, so that's population health? Yeah, that's what it is. That's all I have to do? Yeah. And you put more money in my pocket as a result of that? Yeah, we did. I mean, I think we've got to make it a little bit more Pavlovian, perhaps, or whatever. And so when I look at these action steps here, again, the question is it better to use those resources to enable from the bottom up and spend less time? Not that the top-down concepts aren't important and have a place, but is that the right
in some audiences?
In some audiences.
So, those points, take those points and tie them to the other points that have been made around the table. I think, to go back to this idea of a sort of a joint summit with this group and the directors of the ACHs at the appropriate time, I think it is a way of addressing what I've heard is a concern out there, which is, are the ACHs, forget the sustainability issue, are the ACHs just becoming another sort of bureaucratic silo at the local level? We hope not, and I think the directors would hope not, but it's also human behavior too. So what can we do to avoid that? Using some of the principles of bottom-up, if you will, grassroots change. That makes sense to people, because that's, as clinicians, that's how they were trained, whether it's behavioral health or physical health, same thing.
That's how you also mobilize the data to become clinically relevant, as opposed to just another static bulletin board of patient progress notes. It's really, to us, the value of pre-manage. It's the living, breathing, approach to patients in real time that gives you clinically relevant information. And that's my only caution around how we choose to define an HIE.
It would help me if we go into a forum like you're suggesting to have the ACHs bring, here are the 3 to 10 projects and or policy changes that need to happen for us to be successful. And that becomes the list.
Somebody record that, that's a great idea.
To me, that gives us something to say, yeah, that resonates with me. I don't know what that is, or I'm not sure that's as important in certain areas.
I would just maybe one edit to that would be the 10 things that they feel that they don't have the bandwidth to solve on their own. They would ask us to help.
That'd be a good category to have.
Yeah. Pushing for the identification of issues that cannot be solved individually by any one ACH, and they need to go in another bucket and be left out.
And we could have a discussion of, is that a fit?
I think this conversation is going somewhere. This is good. Hey, this is great. Great way to start the year.
Okay.
It's also 4 o'clock, folks.
So I want to one second recap. So is that then something that we can take, maybe to the ACH meeting, to try to bring back to this group with the expectation that next time we review that and discuss kind of what true action this group can commit to?
Yes. Show hands.
We've originally discussed this a long time ago. ACH is hard to convene, hard to educate, and facilitate. I mean, that's the core. So do I stand corrected on that? Does anyone remember us?
So that's true. That's true.
And I mean, we stand strong in our ACH on that, and that's the reason why it has value to us. But outside of that, I mean, there's other stuff.
I think it's still true. It's just making sure that we're not going to go in a circle.
but I bet you could come up with something that's out of your control, as Mike suggested,
Sure.
that if it was addressed at a broader level, could add value.
If you want to increase Medicaid rates, that would be wonderful.
I'd vote for that.
I think everyone at this table would say we're choice, because, but, do we have that power? It's all gonna come down to the money.
It will. Well, let's take your summary as an action step. And, this group meets again in March. The directors meet monthly?
Oh, the directors meet weekly by phone.
Okay. So after the assessments are done, we'll have had a chance to,
That would be around June. Maybe that's June would be a good time to plan, even if they're not 100%, put in the report that's gonna be submitted to HCA. I think by June, all 9 should have a much better sense of where their potential partnering providers or committed partnering providers are and how these pieces are playing out and interacting.
so that sounds like a long ways away, but there's also a lot of pre-work to be done to make that summit, I'm calling it a summit, successful. So everybody, who's in favor of going in this direction with this kind of a timeline? Show of hands. Okay. Looks like that's the next action step.
And it is, 6 months is far away, but we all know it'll, we'll blink and it'll be gone. But, we also have a lot of ACHs, moving to the financial integration phase of getting that back end worked out. So, want to be thoughtful about how much is getting put in front of them in terms of, where the attentions need to be as these pieces move. So June might be a nice time, not preferable in terms of getting this stuff moving forward on a fast track, but will allow some of that initial work to get out of the way so people can clear their heads a little bit.
In the meantime, this group can tackle some knotty issues that we didn't talk about today that are still on the table for the next couple of meetings. So how about that? Starting at about 4 o'clock, about every minute the traffic volume increases. I'm really thinking about your ability to get back to your office or home, whichever. Thank you for your time. Thank you for coming out today on a rainy day.